The delivery room is a place of incredible, focused energy. But when a newborn is on the way with a known congenital heart defect, that energy can flip from controlled anticipation to, well, chaos. So today, we're going to break down a systematic approach that can transform that chaos right back into control, making all the difference in those first critical moments. And you should know, this isn't some rare event we're talking about. Every 15 minutes, right here in the United States, a baby is born with a congenital heart defect. That makes it the single most common birth defect there is. The challenge isn't just real, it's constant. So how does a medical team face this constant challenge? How do you turn that potential for chaos into calm, effective control? Well, the answer isn't about just reacting faster, it's about anticipating better. It's all about a structured, proactive approach that starts long before that baby even takes its first breath. Okay, so here's our game plan for today. We'll start by really understanding what's going on with these newborns. Then we'll get into a powerful pre-delivery checklist that's designed to predict and prepare for trouble. We'll see how it all works in a couple of real-world scenarios, talk about what to do when things go south, and finally wrap up with the most crucial element of all, the team. Here's the paradox of congenital heart disease. Most of these newborns actually look great at birth. They seem vigorous, perfectly healthy, but that stability can be incredibly fragile. A baby that looks fine 1 minute can deteriorate with frightening speed. And that's exactly why having a team that is prepared for the absolute worst-case scenario is so essential. So how do you get ready for that sudden change? You use a framework, and I want you to think of this just like a pilot's pre-flight checklist. It's a simple set of questions reviewed before the delivery that forces the entire team to just pause, to get on the same page and anticipate problems before they ever happen. It's the key to being proactive, not reactive. And here it is. 6 crucial questions. First, do we expect this baby to be in trouble right away? This sets the urgency from the very first second. Second, are there any hidden dangers? Things like a restrictive atrial septum, which is basically a blockage between the heart's upper chambers. This one little detail can predict a sudden collapse. Third and fourth, do we need to change our normal targets for heart rate and oxygen? Because for these babies, a normal number can actually be harmful. Fifth, is there a risk of poor blood flow to the body? This tells us if we need to have specific meds ready to go. And finally, number 6, what extra people, what extra drugs, what extra equipment do we need in this room right now before we need them? All right, so now that we have the framework, let's actually put it to the test. We're going to apply this 6-question checklist to 2 really common and critical congenital heart diseases. And you'll see how it goes from just a list of questions to a specific life-saving game plan that's tailored to that individual baby. So our first case is hypoplastic left heart syndrome, or HLHS. If you look at the diagram, you can see that the entire left side of the heart, the side that's supposed to pump oxygen-rich blood to the body, is severely underdeveloped. This basically forces the right side of the heart to do double duty. It has to pump blood to both the lungs and the entire body through a tiny vessel called the ductus arteriosus. So let's run our checklist for HLHS. Do we anticipate instability? Well, the answer is a critical it depends. It all comes down to that atrial septum we talked about. Do we modify oxygen targets? Yes, absolutely. We're going to aim lower, around 75 to 85%, because too much oxygen can actually unbalance their whole circulation. Blood flow issues? Yep. And again, that hinges on the atrial septum. And what resources do we need? We know for sure we'll need secure IV access, a continuous infusion of a medication called prostaglandin or PGE to keep that ductus open, and we need cardiology on immediate standby. Now, this slide really shows you why question number 2 on our checklist is so vital. With an open or unrestrictive atrial septum, the baby is often stable at first. But if that septum is restrictive, what we call RAS, it is a full-blown medical emergency from the moment of birth. We have to anticipate immediate cardiorespiratory failure and be ready for an urgent invasive intervention. See, it's the same diagnosis, but that one anatomical detail creates 2 wildly different scenarios in the delivery room. Okay, our second case, detransposition of the great arteries, or DTGA. The simplest way to think about this one is like a plumbing problem. The 2 main pipes leaving the heart are just swapped. So this creates 2 separate closed-loop circuits. You have blue blood going out to the body and coming back blue, and red blood going to the lungs and coming back red. Without some place for those 2 circuits to mix, this condition is fatal. So let's apply our framework to DTGA. Instability? Once again, it depends, but this time it depends on how well the blood can mix between those two circuits. Oxygen target? Yes, 75 to 85%. Here's the key. The problem isn't getting oxygen into the blood, it's getting that oxygenated blood to the body. So systemic blood flow isn't the main issue, but severe low oxygen hypoxemia from poor mixing, that is the critical danger. And for resources, we need the same setup: IV access, PG, and cardiology ready for an emergency procedure to create better mixing. So for DTGA, the whole game is about making sure there's enough mixing of that oxygenated and deoxygenated blood. Stability is completely dependent on keeping natural pathways open, like the atrial septum and the ductus arteriosus, which is exactly why we use that PGA infusion. And just like with HLHS, a restrictive atrial septum that prevents mixing is a code blue emergency that needs immediate intervention. But even with the best plan in the world, some of these infants, especially the ones with those high-risk features we've identified, are going to become unstable. And this is where preparation meets performance. The team has to be ready to adapt, to change course, and execute immediate, decisive stabilization steps. Now, this table lays out the immediate actions for different high-risk conditions, and I want you to notice something really important here. For both HLHS with a restrictive atrial septum and DTGA with a restrictive atrial septum, the first steps are almost identical: intubate, sedate, paralyze, and start PGE. And that's true even though their main risks are different. This shows us there's a fundamental pathway for stabilizing these most critically ill newborns. So why are those the steps? Because when a baby with critical congenital heart disease is crashing, it really all boils down to two simple goals. Everything we do is aimed at minimizing the body's demand for oxygen and maximizing the heart's ability to supply it. Intubation, sedation, paralysis, all of that dramatically reduces the body's oxygen consumption, and that buys us precious time. Okay, so we've covered the science, we've covered the framework and the emergency protocols, but the single most important variable in that room isn't an algorithm or a medication, it's the team. A coordinated, communicating group of people is what turns a checklist into a life saved. And these behaviors are every bit as important as any clinical skill. Using available information means actually doing the 6-question pre-brief to figure out the risks. Effective communication means the respiratory therapist already knows about the modified oxygen target. In a crisis, just knowing your environment, knowing how to call for help, can be the difference between a successful resuscitation and a tragic preventable outcome. In the end, this entire approach is captured in one powerful sentence from the source material. Preparation doesn't just make things run smoother, it directly impacts a child's life by minimizing how long they are unstable. Every single second of preparation before birth can translate into a better outcome after. And that leaves us with one final, critical question to take back to your own practice. When that high-risk call comes in, is your team truly prepared for those first decisive 10 minutes?